like, since we talked a few months back, what's it been like in the practice? How's it changing in regards to your number of cases, and how are the cases going?
Yeah, we're getting busier and busier every
Really?
month, and it's patient driven. That's what we're seeing. It's so slow getting traction with other medical professionals, and I think a lot of people are hesitant, rightfully so. Anything new, people are hesitant to adopt, and so I think from what we're seeing, from what I'm seeing, it's so patient driven, and thanks to people like you getting the word out there. I mean, patients know what's right for them, and then so they're really seeking it out, and that's where we're seeing our biggest pushes come from patients themselves. Patients willing to travel long distance to get it, and that just shows us that there's a big need out there. I'm seeing, and I know Dr. Brady as well, are more patients who are looking at smaller nodules getting treated.
Really?
Yeah, and I think I've actually just this past couple of weeks, I really kind of started changing my own mindset about that. I think historically we're so trained to think, okay, wait till the nodule gets really big and starts causing trouble, and then we take care of it. That's the surgical approach in the past. You know, we would never do surgery for a smaller nodule just for the sake of it. And I really have started buying into and believing in starting to treat smaller nodules and encouraging patients to do that. Why do we wait for nodules to get 3, 4, 5, 7 centimeters, and then we know they're going to have a second treatment with RFA? Right. I think what we need to start telling patients and informing them that, hey, we can ablate these smaller nodules and get 95, 100% ablation. Whereas these bigger ones, as you well know, we say, okay, 75, 80, 85%, that's a success. So that's a new thing as far as how I'm thinking lately, is let's start encouraging patients. Let's zap these early and be rid of them, and you never worry about them again.
I think being proactive can be a good thing.
Absolutely.
I think as long as we keep it balanced, and I'm pretty sure that this is what your mindset is, keeping it balanced where it's not like we're going to treat every single nodule we see, even the teeny tiny ones, but definitely treating those nodules that are not so big yet that they're going to be difficult to treat.
Exactly right. Well, like we talked about on your program a few months ago, all the tools in our toolkit, right?
Right.
And that's what I hope you're seeing here today, that we're doing ultrasounds, FNAs, RFA, and then OR for the cases that need surgery. So combining, mixing, and matching is a good point.
How many cases do you see typically in a month now? Since you said it's growing a lot.
It is. I know Dr. Brady did a bunch last month. I think we had 12 last month.
Wow.
We were before that doing 2 or 3 a month. We have 3 today. We have 3 next week. So we're about 10 to 15 a month right now. Every case brings a little bit something different. We're kind of fine tuning the probe size, the energy amount that we're using. Volume matters as far as how busy you are and your breadth of experience. So we continue to grow our number of cases. We definitely feel like we're adding significant expertise.
I'm curious because as I mentioned a minute ago, I have observed a few different practices doing RFA, and I'm curious, something I saw today that I have not seen in other practices is you have a staff member in the room calling out numbers. What does that mean, and how does that help you while you're doing the procedure?
First of all, thanks to Laura and Victoria and Jenny, our staff, because as you see, they're great, and it's definitely a team approach here at our practice, and they like being in there with us. We love having them in there to help us, and they provide some really useful help as well. So the numbers they're calling out in those videos is the resistance or the impedance that the machine is registering. We're using that as one indicator as far as if an area of the thyroid has been successfully treated. We're looking at the ultrasound screen for the visual confirmation. See the hyperechoic feedback on the screen. We're listening for the pop that you hear us talking about there that you felt. Great. So that's our auditory confirmation. Or if the patient says, "Oh, I feel a pop," that's okay. We see it on the screen. It popped. If we don't get those, but you hear the staff calling out the impedance, typically it's 90 to 100, 110, and then it will rise rapidly when the resistance rises. That's something that says, okay, even though I may not have those other cues, with that resistance going up, that area is done. I'm going to move on to another area. So we have those 3, visual, auditory, and the impedance, all telling us that we had a successful treatment in that one little spot.
That is really interesting because for those of us who don't know about ultrasound really and understand what we're looking at, I mean, the vast majority of patients, myself included, when we look at the screen, it just looks like a bunch of gray.
Right.
And so I actually did have the opportunity recently to do an ablation on some chicken, which was so much fun.
Yeah, of course.
I was really, and honestly, it gave me a great deal, even more respect for those of you who learn to do this.
Mm-hmm.
Because there is so much that you have to be able to do simultaneously.
Yep.
Making sure the probe's in the right place, making sure you've got your ultrasound one in the right plane, and then watching the screen. And as you were just mentioning, talking through those numbers, understanding that you've treated, I was kind of thinking through that as I was doing it. I was like, how do I know where I've done, where I haven't? Because after I moved the probe, I kind of lost sight of what I had already done.
Right.
So that's really great that you have that kind of fail-safe feedback in there to give you that information. So that is very interesting to me. I'm very in awe of the fact that you can look at the ultrasound and understand what you're doing, and actually treat the nodule and not really miss any spots, and actually shrink these nodules down and not have problems later on where like, oh, I missed a spot.
And that can happen for sure. It can happen, and you see. Well, back to the benefit. I say it too much. The full tool chest of doing ultrasounds and FNAs on our own as surgeons is that we do thousands of ultrasounds ourselves, and so that has made us ready to transition more easily into doing the RFAs, because we're not just learning how to do an ultrasound at the same time we're starting to do RFAs. We've done thousands of these, so we're very comfortable with ultrasound, as you see. And what you saw in the chickens and you see here is when you ablate an area, you get that bright white hyperechoic feedback, which blocks the ultrasound from looking any further back. So you have to have the approach that we learned from the proctors we went to in Brazil with, that where you start posteriorly. And then move. And then move anteriorly. If you start in the anterior aspect, now your ultrasound can't see anything back there. And so, and it still can be difficult. You start posteriorly like you're supposed to, you get that scatter. It just all of a sudden you have a lot of bright spots, and it does start getting a little more confusing when you ablate bigger areas. So you have to have a systematic approach. You can't just, as you well know, you can't just go at it willy-nilly and see. You have to have definitely a systematic approach, the point and shoot technique that we use. And you see the vital structures too, of course, that are the trachea, the carotid. You know where the nerve is. You hear us talking to the patient, how you doing? You want to make sure their voice is okay, because that heat can transmit. And so we're always keenly aware of the other vital structures close by.
Let's talk about hydrodissection. Was that something that you did today, or is that something you only have to do some of the time?
I do it less than I used to. So I do it with the lidocaine. When I first started, create that plane, push the carotid a little bit away, so we can get that lateral approach. When I learned it down in Brazil, they did quite a bit of that, and I've been talking to different people that people are doing less of that. First of all, the patients aren't needing as much for pain control. Secondly, I think all of us who are doing them a lot are getting better at being able to kind of put that probe exactly where we need to put it, at the exact energy level to get just to that margin we need to safely. I think starting out, a lot of hydrodissection is really a good point to give yourself that buffer zone of, okay, I'm just learning how to do this just in case I don't want that thermal energy to go too far. I think hydrodissection is important. So I think a little bit is enough after you've done a fair number to kind of avoid getting into trouble. I think my biggest takeaway is patient-driven desire and patient satisfaction. It really is. So I think we're so used to the reverse. Doctor referring somebody in, us advising them. It's been really neat to see patients come in.
So patients are coming to you. You're not treating patients that are primarily not treating patients that are already here for...
We are. We're actually, we're catching up with a lot of our patients who've been coming into the practice for a while, following nodules, and we're converting them to, hey, let's get this with RFA. But we're getting so many patients who are now coming in. The first patient we did today, she came in and she didn't even want to hear me explain anything. She's like, let's just go. Come on, let's do this. So that's been impressive to me to see how excited patients are just to get in, get it done. We all know with Google and the web, patients are well educated these days. So
definitely.
A lot of this, there's no convincing a lot of these patients. You don't have to. They come in, they know it's the right thing. Once they meet you and know you're the right physician for them, they're ready to go. So that's probably the biggest thing. This is the future for sure for thyroid nodules. And like we said earlier, smaller nodules, I think, is going to be the next frontier, waiting for the insurance companies to catch up. The big thing that we always say is just crazy now.
Get that CPT code. That would be
Yeah.
really great.
Yep, that's yes, because we do have patients who unfortunately can't afford the out-of-pocket
Right.
expense to get this done. Yeah, we're doing better as
Mhm.
far as helping patients get some reimbursement from the insurance company, showing the need for the procedure. It's still not where it needs to be, so hopefully that's going to be coming more quickly. The insurance companies, some of them are doing a better job now.
That's good.
So patients that want it can get it. We still have patients who come in and they don't get approval and can't get it done.
My
And so they end up
understanding
going
is-
for major surgery
Yeah.
instead, which is
It's
not
so,
ideal.
It doesn't make sense to me. It's illogical that the insurance company wants to cover an expensive surgery, but they don't want to cover an inexpensive outpatient procedure.
Yeah.
Without the need for those follow-ups and medications after the fact that they're also going to cover.
Yeah.
So I think once they get wise to that fact, that's going to help a lot.
Have you seen a change recently as far as any of the feedback that you get out in the community?
It's exploding.
Exploding.
Yeah,
Yeah.
it's absolutely exploding. I'm seeing a lot more, as you said, the patients are so motivated.
Yeah.
They're so driven, and many times it's like, where can I go to get this? Not why isn't it available where I live? That was a very common thing in the beginning because a lot of patients were just really ambivalent about traveling a long distance. But many of them now are just like, okay, show me the map. Where on the map can I go?
Right.
And we are seeing a whole lot more cancer patients asking, can we have this done? And unfortunately, there are a lot of times where we have to explain to them, there are appropriate candidates and there are very, very inappropriate candidates. Have you had a chance to do a cancer case yet?
Yeah, I'm glad you brought it up.
Yeah.
I have not.
Okay.
Dr. Brady, I think, has done one.
Mm-hmm.
I had a phone consultation yesterday with an out-of-town patient that I'm reviewing right now that I might be doing. So I haven't had the chance yet because it does have to be a very there's a narrow band for the patients that are appropriate. That nodule has to be confident we can do 100% ablation on a cancer nodule. Right. So it has to be in an area of the thyroid that's amenable to 100% ablation. No concern for lymph nodes or any spread. And then can't be too big. We'd have to tackle a small one. So, but it's for sure that's going to be. I think for smaller nodules, I don't know. There's no absolute cutoff. Maybe under 2 centimeters. I think those cancers in the future,
up to 2 centimeters. You think?
Well, I think that's my guess.
You think that's where
it'll
so.
head? Yeah.
I think
less than 10.
Read that somewhere. That's what they've studied is up to 2 centimeters.
Yeah, I may have seen an article with that number.
I'm not
aware of
anyone who's done a 2 centimeter. It's all under 1.5.
Got it.
So.
And we know under 10 millimeters, capillaries can be observed, without big risk. So 1 to 2 kind of seems like the number that we'll be approaching. So we'll see. But no, we're keeping our eye out. We want to try to treat some patients with papillary cancer with RFA.
Well, if you ever get a chance to do that, please let me know.
Absolutely.
Because that is probably the most common question I'm getting now is who's doing cancers.
Yeah.
Patients are asking if we'll make a list of providers that just do that are willing to do treat cancers, and we always want to make sure we're educating the patients, and helping them understand those limits to what this is appropriate for.
It's a risk. We all need to be careful with that. We don't want to be too cavalier with this.
Exactly.
Because if we treat a cancer, we're all concerned that we can't follow it appropriately.
Exactly.
The ultrasound imaging changes completely. The appearance changes on ultrasound, as we see during the procedure. You kill tissue, you make it denser, it becomes hyperechoic. So a hyperechoic finding on ultrasound looks like a cancer. Looks like calcifications, looks like fibrous bands. So the follow-up after treating a nodule with ablation, if you were to take that patient and have somebody look at it with an ultrasound who didn't know otherwise, they would probably say, hey, that's a cancer. That's just how it looks after treating a benign nodule. So we won't be able to look, we don't think, at cancer nodules afterwards and have subtle findings that may alert us to a cancer still being there. The other issue is the biopsies. So follow-up biopsies, if you have inflammatory changes, scar tissue, doing a follow-up biopsy to say, do we still have cancer in there? Those changes in the tissue itself might be confusing for the pathologist to look under the microscope.
On a nodule, on the tissue that's already been treated?
Yeah. Tissue that's already been treated, it's altered.
Yes.
There'll be inflammatory cells, there's going to be changes, scar tissue, So it could make it more difficult for a pathologist to look at it and say cancer or no cancer. So with the ultrasound and biopsies, those are our two tools to test for cancer. And so when we alter those with RFA, that's the concern. Is something hiding in there that we're just not aware of? But with time, we're going to figure out how to follow them appropriately and safely.
Yeah. That'll be interesting if there is another component that could come into that
to help us.
To help with that, like you were talking about with the impedance, how that gives you that feedback that you need. And I think that may be what's kind of the missing link in the cancer treatment with RFA. So that will be neat to see how that evolves.
Yeah, I think anyone considering doing this, wanting to do this, start doing ultrasounds.
Right.
You have to do thousands of ultrasounds so that those subtle things we're talking about, while you're doing this type of advanced treatment, you're familiar with on the screen. So that's step number one. You're exactly right.
How many biopsies and ultrasounds do you think you've done?
Oh.
Have you lost count many years ago?
Probably lost count. I mean, we'll have weeks where we have 80 or 100 patients come through the clinic, so everyone gets an ultrasound.
Right.
Absolutely, every patient that walks through that door gets an ultrasound.
Yeah.
20 or 30% of them, depending, are getting biopsies. So yeah, we do quite a few. And patients will ask us sometimes, do you have to do an ultrasound? I have this report, and I used to feel badly, saying yes, we need to do another ultrasound. Now I don't even. I confidently tell them that yes. I can't tell you the number of times an outside report is different than what I'm seeing. And so we always confirm with our own eyes and our own hands that this is what I'm seeing on you. That's how I take care of you.
That's very important.
Yeah. I'm surprised to think still, and I used to do it, before I started doing a lot of ultrasounds, that reading a report and then treating, not with RFA obviously, but going to the operating room based on something you read on a printed page. Like that is, to me, so foreign now.
Yes.
We do ultrasounds in the operating room. At every case we do, we'll do an ultrasound as soon as the patient goes to sleep, just to confirm correct side, this is the correct thing I'm seeing, same plan I had before. So anyway, just a word to anyone out there doing thyroid or parathyroid surgery, there's no way you can properly practice in this field without doing ultrasounds yourself.
Imaging is so important.
Absolutely.
You've got to see what you're dealing with before you get in there. So I had my 3-year follow-up. That's why I came to Texas.
Yeah, how's it looking?
So after 3 years and 2 RFAs, I have 90% reduction.
Nice.
And I have maintained that. It's been stable for the past year.
Great.
So that was a concern because there was a tiny margin of remaining tissue. Mine was partly really low, below the collarbone.
Yeah, I remember you said he did the first treatment to kind of help pull it up a little bit.
Yeah, it moved upward and then he got the rest of it, but there was this small margin, and I forget which structure it was near, but it was near some very important structure in the neck, and he didn't want to get too close.
Yep.
So that was the concern that he wanted to watch over the next several years to see if that margin regrew.
Right.
And so far it has not.
Yeah, good. So to buy into that mindset, as you call it, of success, hey, we're getting an 80% reduction, and that's success. It was tough at first to kind of.
I'm sure.
But the patients are so happy, and in the beginning you almost felt like, oh, they're not going to be happy if it's not 100%. But patients come in so happy, I'm so happy it's down, and it's a different mindset. But once you see the patient's feedback, you realize it is the right way to go. Right?
Yeah, very, very infrequently I will see a patient say, well, why doesn't it ever completely go away?
Yeah.
But then when they finally understand, well, it's not really about making it go away. It's about reducing the symptoms.
That's it.
I mean, I am thrilled with my 90%.
Yeah, you should be. That's great.
Absolutely thrilled.
Yeah, we had one patient go back to see the referring doc a few months back, and the referring doc called and said, it was 2 weeks after the ablation. The referring doc called and said, it didn't work. I can still see it on the ultrasound. We said,
give it time.
Exactly. We said, it's going to take 6 months at least, and so but that education it's up to us to do that.
Yes.
To make sure everyone understands, the patient primarily, that it's going to take time. It's not put it in there and it disappears. So important on us to provide that education.